Hana Amer, a PhD candidate at the University of South Australia Quality Use of Medicines and Pharmacy Research Centre, and I'm also a registered pharmacist currently practicing in the hospital setting in South Australia. I'd like to take the opportunity to thank JBI and the Evidence Implementation Network for the opportunity to contribute to this digital commentary series. So the paper that I'll be reviewing features in the June 2023 issue of JBI Evidence Implementation and is titled Reporting of COVID-19 Adverse Events Following Immunization in Uasin Gishu County, Kenya, a Best Practice Implementation Report. With the emergence of the COVID-19 pandemic, a number of new vaccines were rapidly developed and provided emergency approval to mitigate the spread of the virus. Given that this approval was based on limited data from clinical trials over a short period of time, and that not all adverse effects will be detected during the clinical trials for vaccines, post-market safety surveillance is vital to detect and report vaccine safety information. So weak vaccine safety surveillance systems in developing countries have contributed to the underreporting of vaccine adverse events. This has undermined public confidence in immunization efforts and also contributed to the low uptake of COVID-19 vaccines. So in Kenya, both a hard copy and an electronic form are available for reporting of adverse events following immunization, or AEFI. However, despite the existence of an electronic form, the reporting of AEFIs have been reported as low. So the aim of this study was to implement vaccine safety surveillance best possible practices to improve the reporting of adverse events following immunization during COVID-19 vaccine rollout in the Uasin Gishu County. The study was carried out in 12 health facilities providing COVID-19 vaccination services, the majority of these being in rural settings. And this project used the JBI Practical Application of Clinical Evidence System, or JBI PACES, and the Getting Research into Practice, or GRIP, Audit and Feedback tool. And so this involved 3 key phases. So phase 1 involved establishing a team for the project, which consisted of pharmacy, nursing and vaccinator representatives, as well as health officials, and then working together to undertake a baseline audit, which was based on criteria informed by the evidence. So as part of this, they looked at 6 different criterion. So firstly, the reporting of all adverse events following immunization according to local policy using a standardized form. 2, reporting of adverse events in a timely manner. 3, hard copy reporting forms were available to all healthcare professionals. 4, healthcare professionals providing vaccination receive pharmacovigilance education. 5, healthcare professionals receive practical training on how to correctly complete and submit report forms. And 6, patients receive education about any potential adverse events following immunization prior to receiving a vaccine. And so this phase was really critical for identifying gaps in compliance with best practices and for informing subsequent strategies for improvement. Phase 2 involved reflecting on the results of the baseline audit and designing and implementing strategies to address non-compliance found in the baseline audit. The GRIP Audit and Feedback tool was used to identify barriers and enablers to compliance to best practice. Then phase 3 involved conducting a follow-up audit to assess the outcomes of the interventions implemented and to improve practice and identify future practice issues to be addressed in future audits. So to summarize the results, the baseline audit indicated poor compliance with evidence-based vaccine safety monitoring practices, with the lowest compliance rates recorded in criterion 1 and 3, which measured the reporting of AEFI and the availability of hard copy reporting forms respectively. So the highest compliance was observed in criterion 2, which measures the timeliness of adverse event reporting. In phase 2 of the study, the barriers to compliance identified included staff time constraints due to workload and completing tasks, health professionals reporting inadequate knowledge on vaccine pharmacovigilance. Less than half of those 12 sites had AEFI hard copy forms, including filling and submission of forms. Limited access to airtime and internet bundles for following up on reported cases and submitting reports to the National Pharmacovigilance Portal, and poor attitudes towards reporting of what may be considered as non-serious common adverse events. Furthermore, on the consumer level, less than half of clients received education prior to vaccination. So the interventions implemented to improve compliance included dissemination of the baseline survey findings to healthcare workers, stakeholder sensitization of AEFI reporting, on-job trainings to the vaccinators, supply of AEFI hard copy reporting forms, and the supply of AEFI information and education materials for healthcare providers. And so in the follow-up audit, the most significant improvements were observed in criterion 4, 5 and 6 with compliance scores of 77% and above across all sites. And during the study period, an additional 189 AEFI reports were reported to the National Pharmacovigilance Portal. There was also a 1/3 increase in the number of clients who received education prior to the administration of the vaccine in the post-implementation phase. So these findings suggest that interventions such as stakeholder sensitization, healthcare staff training, and the supply of reporting and education materials can improve compliance with vaccine safety monitoring practices. However, future research is actually required to determine the sustainability of these improvements over time. The use of the rigorous and evidence-based JBI PACES and GRIP framework provided a structured approach to identify and address barriers to compliance with best practices. This, along with comprehensive stakeholder engagement, helped to ensure that the implementation of the COVID-19 vaccine surveillance system was successful in addressing non-compliance and improving the quality of AEFI reporting. However, the authors indicated that there is still room for improvement with AEFI reporting and education for patients prior to vaccination. So in low and middle income countries such as Kenya, the finite resources for public health initiatives are often allocated for the purchase and delivery of vaccines rather than for pharmacovigilance. And this has contributed to the underreporting of adverse events following vaccination, with Africa accounting for less than 1% of AEFI in the global database. So if we look at some pharmacovigilance systems that have been implemented in low and middle income countries, for example, in Brazil, a national vaccine surveillance system was implemented, which includes both passive surveillance through adverse event reporting and also active surveillance through the monitoring of specific adverse events in hospitals. Health workers were trained on how to identify and report adverse events, and a system was established to analyse and respond to reports in a timely manner. In Nigeria, there were previously multiple groups involved in collecting and managing AEFI data, with a lack of routine analysis and utilisation of the data for action. To address this, data triangulation was implemented for existing COVID-19 AEFI data. The data was then utilised to develop an online dashboard that incorporated key indicators aligned with WHO guidelines and national guidance. These efforts to implement vaccine surveillance systems in developing countries have often included investments in training and capacity building, as well as collaboration between national health authorities, local health providers, and international partners. Hospital pharmacists play a critical role in COVID-19 vaccine surveillance by ensuring the safe and effective use of vaccines within the hospital setting. They are involved in monitoring and reporting of AEFI and provide education and training to healthcare professionals on vaccine safety, storage, handling, and administration. Pharmacists work closely with other health professionals to ensure that vaccine safety protocols are followed, adverse events are reported in a timely manner, and that any necessary measures are taken to address any safety concerns. Through actively participating in COVID-19 vaccine surveillance, hospital pharmacists can help to ensure the continued safety and efficacy of these critical vaccines. Reporting of AEFI is an essential part of ensuring ongoing vaccine safety monitoring. Being able to identify and quickly respond to any issues relating to vaccine safety is an essential part of maintaining public trust and confidence in immunisation. In the discussion section of this paper, the authors noted that despite sensitisation of the health providers offering vaccination on reporting of all AEFIs, it was suspected that minor AEFIs were still not reported. So health providers' attitudes towards reporting of minor AEFIs should be explored in future studies, following implementation of a targeted approach to improve the reporting of minor adverse events. This could potentially be achieved through pharmacist education of healthcare staff during in-services or clinical education activities, and ensuring that any educational material provided emphasises the importance of reporting any adverse event, no matter how insignificant it may be perceived. Establishing centralised vaccine surveillance systems and digital tools that enable ongoing monitoring and evaluation of important indicators and AEFIs in developing countries is vital. This strengthens COVID-19 vaccine monitoring and evaluation, which not only reduces vaccine hesitancy and improves the uptake of COVID-19 immunization, but also enhances the capacity of health systems. By investing in and expanding surveillance, monitoring, and evaluation capabilities, these systems can be leveraged to support other vaccination and disease programs and the skilled workforce that maintains them. However, it is also important to recognise governance and financial resources are also very common barriers for many healthcare implementation projects in low and middle income countries. Therefore, these factors must be taken into consideration when planning any implementation projects. This can be seen in Kenya, for example, where despite the existence of an electronic form, the reporting of AEFIs was low in the baseline audit, for which limited access to airtime and internet bundles for following up on reported cases and submitting reports to the National Pharmacovigilance Portal was an identified barrier. The World Health Organization has recognized the importance of vaccine safety monitoring, particularly in low and middle income countries where such surveillance may be limited. To address this, the World Health Organization has developed a training program aimed at strengthening vaccine safety monitoring in these settings. The program consists of modules that cover various aspects of vaccine safety surveillance, signal detection, and outbreak response. The program is designed to be adaptable to local contexts and can be tailored to the needs and resources of individual countries. By improving the capacity of healthcare workers and public health officials in these areas, the World Health Organization hopes to enhance the safety and effectiveness of vaccination programs in resource-limited settings. To conclude, this implementation project utilised a vigorous and evidence-based approach to successfully identify and address barriers to compliance with best practices for COVID-19 vaccine safety surveillance in the Uasin Gishu County in Kenya. The authors have demonstrated that in low and middle income countries such as Kenya with limited healthcare resources, simple cost-effective strategies such as those utilised in this project can be implemented with measurable impacts. Thank you for taking the time to listen to my commentary. I'd also like to thank the authors of this paper and the JBI network for the opportunity to provide my commentary.